initial graduate, postgraduate and plastic surgery training at Christian Medical College and Hospital, Ludhiana, and later had advanced training in reconstructive microsurgery at St. Vincent's Hospital, Melbourne, Australia. He worked at All Indian Institute of Medical Sciences, New Delhi from 1984 to 1999, and then at Sir Gangaram Hospital. In 2009, he joined Vedanta, the Medicity Hospital, where he established the Department of Plastic Surgery. He has guided many research projects and published extensively in national and international journals. He is a past president of Delhi State Chapter of APSI, Indian Society of Reconstructive Microsurgery, and Association of Plastic Surgeons of India. Over to Dr. Rakesh Kumar.
Thank you. Thank you for the kind introduction. Thank you, chairpersons and colleagues. I am your today's opening batsman, and we have to see whether I end up like KL Rahul or like maybe you would want Shubman Gill here, the local Chandigarh boy. So the subject given to me today is common legal pitfalls in taking consent. So first we need to understand what is consent. Consent is an agreement with two people where they are in making a contract on something, and when one person is proposing something, the other person has to agree to do that. So that is what is called consent. And consent is not something to be taken very lightly. It's the most important document in a patient's record. So it's a legal requirement and it has to be taken seriously, and that is the first common pitfall, I think, is that we don't take consent seriously. We don't take it seriously, we don't have enough knowledge about it, we don't execute the process of consent properly. So this is the first or the most important pitfall, and everything else that comes out from this. So our knowledge about consent process, is it good enough? I think I'm close to my retirement, and when the subject was given to me and when I went deeper into it, then I realized how stupid I've been, how naive I've been, I've been taking consent for a long time and not really always taking it the right way. So we need to know why we need consent, what are the types of consent, and before giving consent, what is the requirement that those are must meet requirements that must happen, and what should be the structure of a consent. So I'll just briefly touch on this aspect before going into the pitfalls. Why consent? In the Indian Contract Act, which was laid down in 1872, when two or more persons are said to consent when they agree upon the same thing in the same sense. And then comes the law of tort. Under law of tort, one aspect is battery. This is the type of tort, it's a civil wrong, which is committed when there is an unlawful contact with or trespass to a person. Now, whenever you examine a patient, do anything, there is going to be a contact with that person. When does that become unlawful? That is what we need to understand. And now, lastly, it's patient's legal right to consent to whatever is being proposed to that patient. So different types of consent that you have to know is, one is implied consent. And the implied consent is when you are examining a patient, abdominal examination, usual general physical examination. But even for that, you've got to touch the patient. It is better to ask the patient before you examine, or just inform him that this is what you're going to do. Although that is not absolutely necessary, but there is no harm in being a little extra careful. You don't know who is going to turn around and make a complaint. So after implied consent is the express consent. Here the consent has to be taken in some form, which can be verbal. This consent is only for an examination, particularly an invasive examination, if you are going to do a rectal or an internal vaginal examination, or when you are giving intravenous or IM injections, taking blood sample for investigations. All these should have a verbal consent of the patient. Moving on, you need written consent whenever you do any invasive procedure beyond IV, IM injections or blood sampling. Anything beyond that, or maybe even urethral catheterization, you may not need it, but you have to put in an arterial line, or you have to do an endoscopic examination. All those would require a written consent. And occasionally, in some situations, you need a videographed consent, and that is important in patients who are undergoing transplant, specifically when there is live donor involved in the transplant. So the live donor's consent has to be videographed by the specific committee that may be there for that purpose. And the person who is giving consent, there are three most important requirements. One is that it should be voluntary, that is, he is not under any coercion, no fraud is done by the person who is taking the consent, and he is not misinformed on something. He should have capacity to give consent. For example, a minor doesn't have capacity, or somebody who is mentally disturbed may not have capacity, or somebody who is unconscious or not fit for other medical reasons, not coherent, then you would need, that person is not, doesn't have capacity to give consent. In that case, if a consent is required, you will take a proxy consent, and I'll come to that a little later. And lastly, the consent has to be informed consent. That means patient has to be informed about nature of illness, treatment, benefit, risk, what alternatives of treatment are there, what will happen if no treatment is given. So all this has to be informed to the patient. So we talk about proxy consent. Who will give proxy consent? Whenever in a cold case, it will be a next of kin in that order where I have listed here: spouse, adult child, parent, sibling, legal guardian. In case none of these are available and a cold situation is there, a medical superintendent and treating doctor can give consent. In a real emergency where you don't have time to even look for medical superintendent, and any treating doctor along with another doctor in the emergency room can give the consent for a life-saving situation. What should be the structure of the consent? I have looked around everywhere. There is no legally defined structure of the consent. Every person, every hospital, every nursing home should have to have their own consent process, and that is different. That may be a little bit different for everybody, but the main body of content is what is defined. The body of content is based on guidelines which are issued by National Medical Council, there are case laws on that, there are directions by Supreme Court, and there may be directions by medical associations that you have to follow. In the end, every person involved in the process of taking consent, hospital, nursing home, clinic, should actually lay down a standard operating procedure of the consent process. So that is something, this is the Vedanta standard operating procedure. It runs into 15 pages. It says who has authorized the consent process, what is the consent process, and purpose, scope, all these things are actually laid down, and this is something that one is expected to follow, and that gives us the umbrella of protection against any litigation, that this is the process laid down by the hospital. It's based on, of course, all the legal points and all the guidelines and all the requirements of accreditation associations like NABH, GCI. So all those criteria are met. So this is our protection of umbrella, that we follow the proper process of consent. So the consent, this is a general consent which is taken by any patient who gets admitted, and then for surgical procedure you need specific consent, or any other interventional procedure. So this is the printed part is only the structure. The actual operational part has to be entered with, is handwritten. It has to be entered by pen. For example, as it is detailed here, what is the diagnosis, surgery, who's doing the surgery, benefits, the points that I mentioned earlier, they all come here. A major issue comes when patient may later say that I didn't understand anything, I don't know English. So something in this area here, patient declaration, we have to ask the patient to write down here in whatever language. If he writes in English, obviously then he understands that. Otherwise he writes in Hindi or any other language that he is familiar with. He has to write that I have been explained all this and I understand all this. I think this is an additional protection that you will have. It may not be the final protection, but that's the best you can do in situation like that when all your consents are in English. So for anesthesia, you need a separate consent, and this is the anesthetic consent that we use. So going on, I will just touch upon some of the cases where doctors have lost cases because of problems with consents. So here is a patient who had undergone ERCP, sphincterotomy and stenting. Initial diagnosis was stones, but he was found to have round worms in the CBD. He was discharged in the evening, and by next day he had some abdominal discomfort, distension. Eventually he actually had, the stent had migrated, perforated the duodenum, had localized peritonitis. He had to be reoperated. So he sued the doctor. Now the outcome was that although it was concluded that there was no negligence in this case, the management was fine, but the process, the consent was not there. No consent could be produced. He said no consent was taken, leave aside no informed consent was there. So that was seen as deficiency in service, and I think an award of about 10 lakhs was there. So that is where, first thing, you must have the consent, must be in the record and must be presented to the court as and when required. This is one of the oldest cases. I think the first case in India post-independence time about consent. The operation actually happened in 1958. The judgment, final judgment is in 1984. It's very interesting because there is a lot of controversy even in my mind, because I don't agree with this judgment. For 1958, patient was operated for appendicectomy through a gridiron incision, and the surgeon found that his appendix was normal. He could see through that incision that the gallbladder was inflamed and the tip was gangrenous. So he closed that incision, put another incision subcostal, did cholecystectomy. Patient had complications post-op and died. So the point here, besides many other points about the facilities available and all, one major point was that he had consent only for appendicectomy and not for cholecystectomy. He should not have done cholecystectomy. And eventually, after the doctor won in the lower courts, but in high court level, the judge opined that he cannot, if you are doing an operation which is significantly more morbid than something that you have consented for, then he should have closed up and woken the patient up, taken the consent, and then done that process. So again, this was went against the doctors. Little controversial judgment in my opinion. This is a patient who underwent cesarean section, which was second cesarean section. The doctor operating at that time found extensive adhesions, and she thought that anything for this patient to have a third child was going to be dangerous. She ostensibly, patient was under spinal anesthesia, asked the patient, asked the family, and did tubal ligation. So the patient was according to the whatever is available, was initially under spinal anesthesia and later under GA because they had to add that. So again, this because the consent for tubal ligation was not taken, this decision also went against the doctors. But once again, it was deficiency in service and not negligence. So the lesson here is that consent should be taken prior to administration of any sedation or any anesthesia, and not. They also said that if patient is under anesthesia, that consent is not valid. So that was another reason this was not agreed to. This is again a very famous case. Patient gynecology. I see a lot of gynecologists here, obstetricians and gynecologists. So a lot of cases here. Consent was for diagnostic and operative laparoscopy. There was extensive endometriosis. The doctor talked to the mother, took consent, did a salpingo-oophorectomy and hysterectomy. Once again, this case lasted for a long time, and the judgment was against the doctor. A fine was imposed for deficiency in service. Again, no negligence was found in this case. I think that's at least one part which is good. That it wasn't negligence, but deficiency in service. This case is a patient who was an elderly gentleman, had cataract surgery, loss of vision after cataract surgery. The consent here was signed by the old man's grandson, although the grandson was an adult. But again, the court ruled that if the person who's undergoing the procedure, if he has capacity to give consent, then there is nobody else's consent is valid. He or she has to give that consent. So proxy consent is valid only when patient does not have capacity. So blood transfusion here. In a surgical consent, we always have a line that you will give blood if it is required. But here is a patient who had, the blood was transfused actually in the post-operative period, not intra-operative. And this patient had AIDS. There were issues with where the blood came from, that was separate. But again, the fact remained that no consent was taken for, separate consent was taken for blood transfusion. So if you are transfusing blood, you have to have a separate consent for that. So that will be part of our standard operating procedure that I have shown you earlier. In this patient, was admitted with perforated appendix sort of situation, and the surgeon did not operate the next day for 2 days. The surgery was done after 2 days. His defense was, and patient of post-op had complications and died, and his defense was that the patient refused to give consent, that is why he could not operate earlier. But again, if refusal to give consent also has to be recorded and preferably signed by the patient that he is not consenting to surgery. Since this record was not there, so this argument was thrown out of the window and the punishment or fine was imposed. So the lesson is that if patient is not giving consent, make him sign on in the file. If he doesn't sign, you make a record that he is not consenting. Lack of consent is only valid in life-threatening situations where again you take a proxy consent and proceed with the procedure. Another post-appendicectomy patient had developed an abscess re-exploration done without separate consent. You need, if you are doing a second procedure, you need again consent. It is not a continuum of the previous procedure that you have done. Post-prostatectomy, this is again a contentious case, post-prostatectomy rectourethral fistula. Patient sued for deficiency, for negligence. There was no issue about consent here, the consent was given. But the National Commission observed that the informed consent cum undertaking was a printed informed consent. It was not a pre-printed, that is an unfair trade practice. And I think we all have pre-printed consents, but the main body, the operational part is something which is written by hand. So obviously, Supreme Court has granted a stay. This is not yet in operation, but the final word is yet to come out. So I'll conclude by saying that please take the consent process seriously. Seriously in letter and spirit and execute it. Have your SOPs. It's a legal requirement, it's not a formality. What will be good is that if we allocate separate time and consult there should be a separate consult and time booked for taking consent. You have to spend that time with the patient and as far as possible do it yourself or a member of your team. Set up your SOPs and follow them and never, sorry, it's not nerve, I got a spelling error here. Never try to change anything which is on the consent. Don't add or subtract anything later because that amounts to you will change your allegation from deficiency in service to negligence because that is an admission of guilt if you are overwriting or cutting something. So on consent form, no overwriting, no addition, subtraction later on. Thank you for your attention, please. I hope I